All right, so good morning, everyone. My name is Matt Fraioli, and I'm one of the staff therapists at Stamford Health. I have been there for a little over 3 years now.
And I've been lucky enough to join the team for the last 4 months, and I saw a little bit of a protege for myself to mold and get up here with me at these conferences.
So we are from a city, Stamford, Connecticut. See right there, we have a map of where Connecticut is. For those who don't know, we put a little star. So we are much more than just a highway between Manhattan and Boston.
So we work at the Bennett Cancer Center. So we are a community hospital with 2 true beams. They are unfortunately not fully matched. One has different energies, and we only have one SGRT system right now, which is why we're not fully tattooless and markless yet, but we are pending install of our second one, and we'll be transitioning to tattooless and markless. And what I would say is what was really helpful was the last talk, because the last thing we haven't fully embraced for SGRT yet is prone breast, and that's because it's on the machine that doesn't have it yet. So thanks, Samantha, for all those good tips.
So let's go over the agenda for today. I'm first going to introduce you to what we do in the sim for every patient, since we only have one machine with the SGRT system. So we do put marks with tegaderms on every patient in the sim. Just in case the machine with the SGRT does go down, we could send them and have the ability to go to the other true beam.
Yeah.
So if we start to see a patient losing marks, we will give them new ones on the SGRT machine. We're also going to show you what has been working for us in the sim. We're not going to tell you the right or wrong way to make an immobilization device, but we're going to show you what we do now and what we have found to be tried and true to actually work and not block the cameras. Because if you start blocking the cameras on the SGRT system, you're going to have it jump, and you might be moving them around for a while.
And then that's when you get the people who say, oh, this system doesn't work. So the workflow basically it will be to, and this all, again, I've said this a lot, it all starts in the sim. It's assessing what we're treating, which immobilization device will work best, and can the patient tolerate this position with that immobilization, which is all the same regardless if you're using SGRT or not. But the last step there is really where SGRT comes in, and it's can we draw a suitable region of interest with this immobilization device? And that's where the two are so intertwined, because your immobilization is only as effective as the ROI you can draw, and your ROI is only as effective as the immobilization device that you're making. So those two things cannot be disconnected.
So I've been lucky enough to have multiple months in the sim, and I have learned a lot in the last 1 to 2 years on personal mistakes that I have made, where I will sim a patient, get them to the machine, and our therapist is like, oh, great job, you're blocking this arm now. And I'm like, okay. So I learned how to fix it with a lot of training from Jonathan and our manager, Annie, right back there.
Shout
so now
out.
she can't ask us impossible questions. So we do index everything still. The only thing we do not index is for our heterotopic hip. We just use a basic knee cushion, black knee mobilizer. Everything else we do index. So as you can see here, we have a flex lock for the pelvis. We do all prostates on that. So on the first day, when we treat or have them in the sim, we make sure their knees are just right over the crevice where they're supposed to be. And that way, we don't really run into a lot of pitching.
And what really helps with that is, again, we'll all say it together here, postural video. Really, when we're setting that up, and we can use those outlines to help fine-tune the setup with the flex lock itself, because you'll see if the leg is too pitched and you need to move them up or down.
And the best thing about the flex lock too is you can see there's minimum room for anything to be blocked. You could have free range when you're drawing your ROI while you're doing your chart check, and not have to worry about running into any issues with any blockage from your indexing device. And then we also use the wing board. We do make vac locks for all of our lungs, mid to lower esophaguses, and all of our abdomen patients. So we're going to show you how to do that as well. Here is also our breastboard. We're not going to really talk too much on making the immobilization device for the breastboard, because the only one we do make for the breast patients are for our 3-4 field breast. We do make a mold care for the back of their head, just to make sure their neck is in a reproducible position instead of being on just this little donut. And we have had great success with all of our breast reproducing very well, and our 3-4 field breast.
And what I'll add to that is this breastboard when I first got to Stamford, I was like, oh, great, it's got the 4 cups. But what I will say is it gets the arms in a much better position that you're really doing minimal adjusting with the postural alignment rather than the one that's sort of like a wingboard on top of the breastboard. So I'll give it credit. I was a naysayer at first, but I'll give it credit.
We don't have it on here, but for our prone breastboard, we do have the Orfit Sagitilt, where we do have the ability to actually tilt the board and kind of tilt the heart up and out of the way. So that way it's just the breast tissue hanging down, and that's been working out great for us.
And that's our next project for SGRT.
And then we have the Q-Fix head and neck board that we use for brains and head and necks. And we have a board called the Encompass board that we use for SRSs. So here's a picture of our mask and our vac locks. I think this is
It's cutting out.
in and out. We do open face for mostly everything. This works very well because a lot of our patients do tend to be claustrophobic. So we're like, it's okay, don't worry. Your eyes and your nose, and you're going to be able to breathe. You're going to be able to see, you're going to be able to breathe. The open face allows us to draw our ROI around the face here. So we have had a lot of success with reproducing those patients every day for treatment. We use the Q-Fix vac lock and the 2 Sifco vac locks. We tend to use the Q-Fix one a little bit more just because we have a little bit more in inventory, and we find it a little bit easier to move the patients up and down on it.
So for brain and head and neck, general rules to keep in mind when you're making that mask and sim is you want at least 2 centimeters above the eyebrows to the mask edge. You want clear open face down to at least the hairline. And you could either have the upper lip covered or down to the chin. And you don't want to draw your ROI in the mask itself. So whether you're making the long 5-point mask or a short mask, those are the key points to always keep in mind. And as you'll see in the next slide, the immobilization that we use is the Fibrelast from Civco or CQ Medical, and that gives you a lot of working time, and that is definitely a 2-man job. So when you're making that, you're going to be having one person hold the forehead and the chin while the other pulls the mask down. What's the name of the game, Matt?
You want to go down to the hairline?
Slowly. Slowly. Speed is your enemy. So bring that mask down nice and slow because in your mind's eye, you want your ROI to be able to cover meeting those key points.
Because you're going to be able to tell very easily when they're on treatment if they're pitching their head up and down or rolling side to side. There have been times where we have had to stop treatment and we will re-image because our line RT system says, oh, they pitched their chin up 1.5 degrees, and it always matches up with our imaging. So we always do like a hard stop right there.
And I think what this mask offers is that sort of extra material on the inferior part that you fold up, and it really helps secure the chin. And so the key differences between sort of your standard head and neck setup is you generally want a chin elevated, but that is the opposite of what you want for SRS. So for SRS, you want chin neutral or chin tucked. And that's, again, because you're often dealing with non-conformal beams, and if you're kicking the couch any one direction, you're limiting the visibility of one camera. So if your chin is too elevated, you're going to really limit the visibility of those cameras.
And if you are working at a center that is afraid to kind of shy away from the closed face mask because they're afraid of a lot of movement with the open face, you could tell them if you're using a line RT, you're only using the system to set them up, and then you're not able to use it during treatment. Because if it's looking at a closed face mask, it's not going to be able to tell you much information at all.
And I think we all know they could still move in those masks anyway. So the word immobilization is sort of a misnomer. So at least with the open face, we can see if they've moved and adjust for it.
Okay, so we're going to move on to our thoracic area. So we did touch a little bit on the breast. We're going to touch more on the esophagus area and the lungs and how we make those vac locks. So the key point for making these vac locks is we do arms up for all these on the wing board. You don't want to come around their arms or their elbows because you want to be able to make sure that the vac lock is just the posterior impression of that patient. Because if you start coming up around those arms or even higher than midline on the patient, you're going to limit the ROI that you could draw on your system. And one of the big things that we see is if you go higher than midline on that vac lock, you're going to have consistent rolls. So we like to keep it a little bit lower than midline, which we're going to show you right here on Jonathan. I drew a line from midline. You could see...
I like to volunteer as the test patient.
You can see how his arms are indented, his head is very well indented there, holding onto pegs, and the vac lock is well below midline here. So we have a lot of room. We could draw our ROI from all this AP portion all the way down to his lat area. So we're going to have consistent, accurate readings on a line RT with our roll and rotationals.
So here are just some ideas for different ROIs. So what I said in my talk yesterday, which is what I've stressed to the team, is don't get married to that first ROI. Don't get married to the standard. Make those adjustments based on what you're seeing. So for example, if we're doing like a thorax, we'll start with the one on the left. And if that's not working, if we're getting too much breathing motion, if our vertical is moving up and down too much, we'll transition to the one you would see further to the right. And we'd keep making those adjustments until we had stable deltas.
So now we'll move on to the pelvis. Like I said, we use the flex lock. We like to keep it simple, where we just have that straight index. We do capture parameters on our first day of treatment. So we have a rule of thumb where when we capture those parameters, we will stay within 1 centimeter of those capture parameters on the vert, lunge, and lat. Because if we go above that, then something might be a little wrong. They might be pulled up too much. They might be pulled down too far. So let's keep in our 1 cm of those captured parameters and then move the patient from there.
And I'll admit, when I first got to Stamford, I was like, wow, 1 cm's pretty tight. But having worked there, I could see that it just yields better results in much smaller imaging. And it really works very well with the line RT because what you're trying to achieve is as close to baseline as possible. And by staying within your really tight couch parameters, you're helping to achieve the same idea with the line RT, is keeping those deltas as close to 0 as possible.
Now, we do have a good amount of inpatients that will come down, and let's say we're doing a palliative hip or lower spine or S-spine, we will use the flex lock as well. And these inpatients, they come down, they're hooked up to a lot of things. Some might have these bigger underwears on, they might have like a diaper on. The ROI that we draw is the standard one, which will be right on the sides of the hips, going from about mid-thigh all the way up. But if these patients do have a lot of those extra things on them, we'll draw a little bridge across their pubis area to connect the two ROIs. We see that help a lot.
So for extremities, as we all know here, I think we've gotten to the point where we really see the benefit for extremities. So there's a lot of factors that play a role with those setups. So it could be upper or lower. And again, it's about what is the best immobilization device to use and can they hold this comfortably. So we use SGRT for all our extremity setups. We actually won't put it on our machine that doesn't have it because we've really seen the benefit of it. So when you're treating things like a shoulder, a femur, ankles, hands, arms, we've seen SGRT work on all of these sites, and it really just optimizes those setups.
And our doctors are actually starting to treat a lot more of arthritis patients. So we did actually just purchase the new Orfit extremity board. So we're going to hopefully by this time next year have a lot more information on that too and how those have been setting up.
So here's an example of a shoulder that we recently did. So one of the key rules to always keep in place is when you're doing an extremity, you want to have an ROI over a joint, and the more topography, the better. So the immobilization device should allow for the ROI you need to draw and not get in the way of that. The joint should not be covered by the immobilization, which should be obvious, and vac locks shouldn't go higher than midline and at all for your ROI. And you don't want a flat surface, and that's why you want to include a joint.
So this was a recent leg that we did. And like Jonathan said, you do not want to just draw your ROI. Oh, sorry.
Pretend you didn't see that.
You don't want to draw your ROI just on the upper part of the leg here and not get the knee, or just the lower part and not get the knee at all. Because then your system's not going to know if you're too far up or too far down. Give it a joint. Help it out. Use it to its full potential here. So same thing with the leg and lower vac lock. It's very easy to keep that vac lock to make sure that the feet are indexed, so they're all the way down on it to help create that pitch. And you want to also see how the midline is very high up. So you're going to be able to roll that leg very easily if need be. Now, if you do that too much, then you're going to be moving their knee all the way around. And that might be a little painful. So we're going to give you some visualizations on our actual system with these extremities.
So, and this is where postural alignment really shines. You're really not only just focusing on your region of interest, but you're seeing how each adjustment that you make is reflected in basically your guidelines or your outlines of the patient themselves.
I've seen these treatments go from 30 minutes to 10, 15 minutes for us, which has been a game changer.
Rather than looking at an extremity and going, oh, great, I got one of these coming up, you're like, oh, great, we got an extremity coming up.
Yeah.
It's like those images are like music.
Yeah, we're finding our students like to comp the extremities with us because they get to use the system.
Yeah.
Now here's the shoulder one. You saw an ROI with the shoulder up. This is a setup with the shoulder kind of akimbo. So we just gave it some room away from the body. We made a upper vac lock on either a basic U-frame with a head holder, so they're indexed, or a wingboard if you can make it work too. Because like we said, as long as it's reproducible and comfortable for the patient, we'll kind of play around with everything in the sim.
And note the arrow there that the elbow was sort of just resting in that back lock. It wasn't really being wrapped or encompassed. It's just a point for the elbow to lay and help reproduce.
We want to let Align RT do its job. So the key takeaways are a proper mobilization device can truly optimize your treatment with the SGRT system. Whereas if you do incorrectly make an immobilization device and you're blocking a joint or you're blocking the whole ROI, then you're going to make your lives a little bit harder on the treatment itself. And when the patient's on the table for a longer time, this leads to less than ideal patient satisfaction, and no one wants that.